Good evening and welcome to our spine webinar. I hope everyone is ready to have all your back and neck questions answered. We're going to get started in a moment, but first, please allow me to take a minute to explain tonight's format. In a minute, I'll introduce our panelists and we'll begin taking questions. But in order to keep background noise down, all participants other than our panelists have been muted. If you find yourself somehow having come unmuted, please just go ahead and tap that microphone, turn it red, so that you can keep that background noise down. We do ask that you submit your questions via the Zoom chat feature, which you will find in your Zoom toolbar. We'll take questions as they come in. And if you would like to pose your question to a specific panelist, please let me know when you write your question. Otherwise, it will be asked generally of the group. We've collected a few questions ahead of time, and we'll start with those. And excuse me just one moment while I take a second to make sure that all of our panelists are unmuted. All right. Now for a brief introduction of our OrthoSouth Spine Center. Our back and neck team is the largest multidisciplinary team of spine specialists in the Mid-South region. At the helm are our fellowship-trained spine surgeons who are joining us tonight for this panel. But the majority of back and neck patients will not need to consider surgery, so our team also includes non-operative spine specialists, physiatrists, nurse practitioners, physician assistants, physical therapists, orthobiologic medicine, and even chiropractic services. And I'll let our panelists explain some of those terms in a moment. Now to introduce our panelists, with us tonight, we have Dr. Spencer Hauser, Dr. Stephen Waggoner, Dr. Sam Murrell. Starting with Dr. Hauser, he is a fellowship-trained orthopedic surgeon specializing in both operative and non-operative treatment for spinal deformity, spinal trauma, and degenerative spinal conditions. He also has a special interest in minimally invasive techniques. He practices at our Primacy Parkway and Bartlett Clinic locations. Dr. Stephen Waggoner is another of our fellowship-trained orthopedic surgeons specializing in spinal disorders and minimally invasive spinal surgery. We're noticing a trend here. Dr. Waggoner practices at our Germantown, Poplar Avenue, and Bartlett clinics. Dr. Sam Murrell is our next fellowship-trained orthopedic spine surgeon who focuses on treating disorders of the cervical, thoracic, and lumbar spine. Dr. Murrell practices at our Briarcrest Avenue and South Haven, Mississippi clinic locations. And though he can't be with us tonight, I would like to recognize our fourth surgeon, Dr. Sam Shrellicki, who is also a fellowship-trained orthopedic surgeon specializing in both operative and non-operative treatment for all spine disorders. He has special interest in minimally invasive spine surgery and complex spinal reconstruction, and he practices at our Primacy Parkway and Bartlett clinic locations. And finally, briefly, just a little bit more general information about OrthoSouth. Our truest focus at OrthoSouth is on enhancing the patient experience in orthopedic care. This involves our being available for you where you are and when you need us. To that end, we have 8 clinic locations across the Mid-South region, 2 ambulatory surgery centers, weekend clinic hours in Bartlett, an OrthoStat urgent care clinic in East Memphis with evening hours, and even a 24/7 urgent care line by which you can reach a board-certified orthopedic surgeon for guidance regarding any injury that might occur after hours by dialing 901-261-STAT. You can learn more about our services at orthosouth.org. Now, without further ado, we'll move into the Q&A portion of the evening. We'll start with an introductory question for our panelists, one that I think will be relevant and will kind of kickstart the conversation. Back and neck seem to be 2 areas where there is some overlap between orthopedics and neurosurgeons. Can you explain the difference and when someone would visit you, an orthopedic surgeon versus a neurosurgeon, or perhaps when they could choose either? And why don't we start with Dr. Stephen Waggoner?
Well, I think neurosurgeons as well as spine-trained orthopedic surgeons basically see the same type of patients and do many of the same type of surgeries. Orthopedic trained or a spine-trained orthopedic surgeon does the same type of surgical procedures as a neurosurgeon. I think the orthopedic surgeons are maybe a little bit better trained in the conservative treatment of spinal disorders. The neurosurgeons, they have similar training. They focus also on other intracranial issues such as spinal tumors and strokes and aneurysms and things like that. So they have, other than that, you know, the training is pretty similar for a spine-trained orthopedic surgeon and a neurosurgeon. But again, I think the main difference is the orthopedic surgeon has more trained in the conservative treatment as well as surgical treatment of spinal disorders.
Dr. Murrell or Dr. Hauser, do you guys have anything to add to that?
I don't have a whole lot to add to that. I think that's spot on. Not a whole lot of difference. At one point, there was more difference with regards to neurosurgeons would do more decompressions and just taking pressure off of nerves, and orthopedic surgeons would do more instrumentation. But the lines have been blurred, and it's essentially the same at this point. And like Dr. Waggoner said, with regard to actual disorders within the brain or spinal cord, neurosurgeons probably do a little bit more of that. But with regards to more of the conservative measures and all the stuff you can do before surgery, I'd say we do a lot of that very well as orthopedic surgeons.
Excellent, thank you. Moving on to our next question, we did collect a few of these ahead of time, and here's one from an individual who says, I have been in pain for the last 3 years, had injections and ablations done with no lasting effect. I've given up riding my motorcycle. I can't play golf anymore. What would be next steps from this point? Dr. Murrell, would you like to answer that one?
Well, sure. That's certainly an open-ended question. And I think the first step would be trying to figure out, have we really assessed where the pain's coming from, what our pain generator is? So in a case like this, we certainly like to gather all the evidence that's been collected for us ahead of time. In other words, what kind of imaging studies has he had? And what kind of responses has he had to the treatments that have been performed thus far? And then from there, we can gather on the information and his response to treatment as to whether we're really going down the right path as to what the real pain generator is. Because if we're not identifying that, then I think that we don't really have a chance of trying to resolve his pain.
Excellent. That leads to another, just a really good starting foundational question. Back and neck pain. Someone has it, lots of people have it. Where do they start? Do you suggest starting with primary care physician, physical therapy, or come straight in and see one of our talented surgeons? Dr. Waggoner, would you like to take that one?
Sure. We would always be happy to see anybody with a spine or neck problem, neck or back problem, and either seen initially in our office or referred from their primary care physician. But a lot of patients will go to their primary care physician for advice first. Most spine problems will resolve over the first 2 weeks or so. So they can be most of the time handled by the primary care physician. If the symptoms are not improving, then they can either be referred to see us or call and, you know, make their own appointment to see us. And we'd be happy to see them and evaluate them further and obtain imaging studies, x-rays typically, and start out usually with conservative measures with medications like anti-inflammatories, exercises, sometimes physical therapy. And then if symptoms continue or the symptoms that they're having initially at presentation warrant, then we would do an MRI scan to further assess their problem. But I think they can start either, if it's an acute problem, they can go to their primary care physician, and most of the time their symptoms will resolve. But we also would be happy to see them initially as well.
Thank you. Another kind of bird's eye view question: if someone is experiencing pain in many joints, including their back, from a general orthopedic perspective, where would they begin? I've got pain in my knees, I've got pain in my back and my, my hip. Is there a specific place that's best to start? Dr. Hauser?
So I don't know if there's a specific place that's best to start beyond just getting evaluated by an orthopedic surgeon. Sometimes a primary care doctor can also take care of that, but just having some more information with regards to exactly what joint is bothering them the most, and then kind of going from there, getting appropriate x-rays or even advanced imaging like MRI scans can be helpful if needed. Again, typically you can take care of it, conservatively. Sometimes if there are multiple joint complaints, even something like rheumatology consult can be warranted. So sometimes you'll get to that point, but that's kind of based upon the clinical picture that patient's presenting. I think the other guys might have something else to add. But.
All right. Anybody, Dr. Waggoner or Dr. Murrell, do you have anything to add to that one?
One thing I might add is there's never a wrong place to start, whether that be your primary care physician where you're most comfortable, or whether you feel quite convinced that it's an orthopedic problem and the orthopedist is the place to start with. Because I think that, only by presenting and letting someone hear your complaints can they then direct you to the appropriate provider or alleviate any fears you may have as to whether it is something more ominous, whether that pain that kind of comes towards your anterior chest is coming from your heart, or whether it's really something coming from your neck or your shoulder. And then in the case of an orthopedist, whether that pain in your hip is really coming from your hip or whether it's coming from your back, it may be something that we might be easily able to discern a difference. And so it would be quite appropriate to come to either a hip specialist or a spine specialist, thinking that it's one or the other. And then here at OrthoSouth, we would like to direct you to who the specialist is who could provide you the best care.
Excellent answers. This one is a little specific, but what treatment options are available for foraminal stenosis? Dr. Waggoner?
Was this for cervical foraminal stenosis? Foraminal stenosis at LC7 and T1. That would be usually the C7, that would be the lower cervical spine, and T1, the upper thoracic. But cervical foraminal stenosis can sometimes be treated with a minimally invasive procedure where you go in from the back of the cervical spine and open up the foramen or do a foraminotomy or decompress the nerve root from the back. That it would have to be, the MRI would have to be evaluated first to determine whether that would be the surgical approach. Occasionally it can be done through the anterior approach or through the front of the neck also, with the fusion. Short of surgery, we can do other things such as physical therapy. We often send those patients for cervical epidural injections, which can help, and then treat them with medications such as anti-inflammatories and other medications that can help the radicular pain or arm pain that they're experiencing. But for surgery, it would have to be evaluated further with an MRI before you can make any final determination.
Excellent, thank you. Dr. Hauser, do you have anything to add or any other thoughts on that one?
No, I agree with all that completely. And again, just to emphasize, the vast majority of foraminal stenosis will often cause pain radiating into your arm, and the vast majority of that will get better with non-operative management and this things that Dr. Waggoner just mentioned. Sometimes medications combined with therapy. We usually try at least one or sometimes multiple epidural injections before committing to surgery. And if it gets to the point of surgery, if it's bad enough for that, then there are a few options available. And that becomes more specific on a case-by-case basis. But I agree with everything you said.
Thank you. And at this point, I do want to encourage everyone, please do feel free to ask questions using the Zoom chat feature. It's located in your toolbar. You can just type it in, and then I will ask our panelists their opinions. Dr. Murrell, a question for you. At what point do you consider injections for back pain?
So typically, injections for pure back pain are reserved for those individuals that, one, we don't think they have radicular type complaints, or in other words, pain that's going on down the leg, that the pain is confined to the back, that they have some radiographic finding, such as facet hypertrophy or enlarged small joints there in the back, that would be a potential source of their pain, and that they have a clinical exam that points to that being the source of their pain, and they've not responded to conservative measures, including things like anti-inflammatory medications and physical therapy. And in those cases, something like an injection of the facet or a medial branch block would be done by a team of non-operative physicians, such as a physiatrist or a pain anesthesiologist, who would do those procedures with the idea in mind of trying to diagnose, is that truly the source of the pain, and provide a therapeutic effect, avoiding any kind of surgical procedure for the patient.
Excellent, thank you very much. Dr. Hauser.
Yes.
What are some hallmark symptoms of a, quote, slip disc in the lower back?
So yeah, and that's a good question, because that's probably one of the more common things that we see day in and day out. So some of the more common symptoms that people will notice are some degree of pain often, and that can be pain in the back, pain in the buttock, pain radiating down the leg, some combination of those three. Often patients will feel it shooting down their leg. Sometimes it can be sharp pain. They describe it in many different ways. But it often comes about with an accident or a twisting injury. A lot of people who have that, and this is not all inclusive, but a lot of people will say they felt a pop or twist, or they have an incident where they know that they felt it. A lot of my younger patients that come in with radiating leg pains, it's often coming from a disc herniation. That's often how they'll describe it. They felt a pop after an accident and noticed radiating leg pains. So those are some of the main things that come in. Sometimes people will have some degree of weakness, and we always evaluate for that in the office. But those are typically the main things that they have on the initial evaluation.
Excellent. Dr. Waggoner or Murrell, anything to add?
I think he's covered the vast majority of the symptoms that would be worrisome. Again, truly things that we're always looking for are red flag symptoms, symptoms that would suggest an emergency, which are certainly not common with a disc herniation. But if there's ever an issue of bowel or bladder incontinence, then that becomes a much more urgent matter, and they should contact us or an emergency room right away.
Thank you. Very nice. So another question about back pain in general and the treatment of it. If someone is experiencing pain in their lower back, do you suggest heat application, ice application, both, or does it depend? Dr. Murrell?
So that's a good question, one we get every day. If you've had an acute injury, often we'll recommend cold therapy or ice to prevent some localized swelling. After about 48 to 72 hours, though, presumably that localized swelling is starting to subside. And in many cases, people find that heat is more beneficial. I think the thing to realize is that those are symptomatic treatments, and they are great at treating the symptoms. They don't necessarily address the underlying pathology, but certainly there's nothing wrong with applying heat. It makes us feel better, and you know, we love to see our patients feeling better. I do want to recommend that if you are putting a heating pad, that it be moist heat and not the old electric heating pads that some of us my age might have grown up with. And we do that because we don't want those muscle tissues to dry out, so to speak.
Very interesting.
And I would add to that, just that, and I've seen a few patients come in after applying heat, actually with burns on their skin. So anytime somebody starts asking me that question, and I get that question daily as well, and I answer it just like Dr. Murrell just did. Often ice initially and heat kind of once the initial injury kind of subsides, but just be careful you don't burn yourself, and make sure you've got some padding between where the heat is and the skin. Because I've seen some people actually burn themselves with that.
Very good advice.
Mm-hmm.
All right, we've received a new question from someone who states that they have a degenerative disc disease from L1, S1 with degenerative, oh goodness, arteriolisthesis. Can someone interpret that for me from my horrible pronunciation of it?
Is it spondylolisthesis or anterolisthesis?
Arteriolisthesis.
An anterolisthesis?
Yeah, that's what it sounds like.
That's what it sounds like. And they want to know, at what point do you recommend surgery, and which type of surgery specifically? And Dr. Hauser,
Yeah, I can take that. So what it sounds like you're saying is what's called anterolisthesis. Sometimes it's called spondylolisthesis. And what that means is that there's some instability in the spine, and that the bones are kind of shifting around a little bit more than they normally should. Normally your bones should kind of stay still and in alignment. And if one is shifting forward a little bit compared to the other, it can create symptoms. It can cause pain in the back. It can also sometimes create spinal stenosis or some pinching of the nerves, and can cause pain shooting down the leg. Again, kind of like we've talked about with the other topics we've touched on so far, typically that'll also respond to non-operative management. And I think that most spine providers and orthopedic surgeons that are treating that will try to wear out all non-operative management before jumping to any type of surgery. What I typically tell people is, barring any significant weakness or anything like that, surgery is what you kind of turn to once you've tried all the non-operative management and the pain is bad enough to warrant surgery. So if it's bothering you bad enough and limiting your quality of life, and you tried all the other non-operative management, typically some combination of medications, physical therapy, and injection therapy, and it's not doing the trick for you, then surgery can be an option. Now, what type of surgery specifically is a little bit more complex. That kind of depends on the actual situation, looking at the x-rays and the MRI. Sometimes it's a fusion surgery to stabilize those bones so they're no longer moving back and forth. Sometimes you can just do a decompression surgery where you don't have to put screws and rods in. That's individual based on kind of the x-rays in that particular case.
Excellent, thank you.
Mhm.
Dr. Murrell or Waggoner, anything to add?
I think he's covered most of the options there. I don't know for certain, but I thought that there was a comment that was coming through on the chat room that somebody wanted some information included that they had sent. And I'm assuming it might be referred to this, but I don't know.
Yes, that is true. I did try to shorten it for the sake of brevity, but it includes chronic pain from lumbar spine, which radiates down both legs, more on the left than the right, difficulty walking more than 2 blocks when symptoms worsen until the person sits down, has had an epidural injection 3 weeks ago with minimal relief, and is now looking for other modalities short of surgery.
And certainly that suggests that the pain is involving both the right and left sides, and that there is perhaps narrowing on both sides, affecting both exiting nerve roots. The question, when there was little relief, did it provide some temporary relief? Sometimes it's worth repeating an injection just because it sometimes is not fully effective in that first injection. Other than that, without actually seeing the x-rays, the next option would be to consider whether things are serious enough to consider surgery. And again, it's hard without actually speaking with the individual patient and looking at the x-rays. But it sounds as though this may be a case where it is becoming symptomatic enough that surgery should be considered.
Excellent, thank you both. Our next question for Dr. Waggoner: would acupuncture be an alternative to surgery? And if so, in which cases?
It depends on the symptoms the patient is having. If the patient is having predominantly lower back pain, surgery is usually not a good solution for that. And acupuncture and physical therapy or dry needling may be an option. It's just we'd have to evaluate the case and look at the imaging studies to determine whether it would be something where surgery would be more beneficial or whether acupuncture might even be an option.
Excellent. Here is another question: is it true that having tight hamstrings will cause lower back problems? Dr. Murrell.
So tight hamstrings can be a sign of someone who has a spondylolisthesis, particularly of the type that you might see develop or become symptomatic in earlier years, in late adolescence. But as far as them causing back problems, they're really sometimes more the result of a back problem, but certainly not all tight hamstrings are from having a back condition.
Excellent, thank you. Here is a really good question, very timely and relevant to the times that we're in. Someone who was seeing actually Dr. Cervical late last year and was looking at scheduling surgery around April until we got hit with the pandemic, and has been reluctant to reschedule the surgery, although pain has increased and mobility has decreased over the last few months. this person is asking, what are our recommendations? I think it's a good opportunity to talk about what we're doing in our surgery centers and in our clinics during the COVID pandemic, and ways we're, trying to ensure that everyone, patients, staff, and surgeons alike stay safe. Dr. Waggoner, would you like to speak to that?
Yes. First of all, in the office, we are, being very careful to social distance with the patients. Everyone wears a mask. We take the patient's temperature when they first come into the office, and take the physician's temperatures in the morning to be sure that no one has any fever, which may be associated with COVID. The patients are all asked screening questions when they come in. The staff at the surgery center and at the hospital are all tested for COVID. We have random testing every couple of weeks at the surgery center for staff members. Everybody that comes into the hospital or surgery center for an elective procedure is tested for COVID before their procedure as well. So we're taking multiple precautions to protect these patients and the staff. So I think at this point, it's very safe now to come in and be evaluated in the office, and also very safe to have surgery at the surgery center especially, but also at the hospital. The patients, again, are all screened, and if they're admitted overnight, they're placed on a floor where there are no COVID patients. And so I think it's very safe still to go ahead and proceed with surgery if necessary.
Excellent. Dr. Hauser, I have a question here. What are your opinions about chiropractic intervention for disc and that A word again, and enterolisthesis?
Yeah, so again, a daily question that I get asked multiple times every day that I'm in the office, I would say. And I think that a chiropractic care could do a good job. I tend not to, I think it can do a good job for patients in the right scenario. I have a number of patients who have responded very well to chiropractic care. If it's not working, I usually will say maybe not to keep going back endlessly, but I have a lot of patients who do it. And I recommend it to a lot of people who maybe aren't, especially if patients maybe aren't great surgical candidates or very hesitant to proceed with surgery, and they've kind of tried all the other stuff. They've tried medications, formal physical therapy, focusing on core strengthening and injections. I'll often send patients for chiropractic treatment to see if that can maybe afford them some relief and they can avoid surgery.
Excellent, thank you.
I don't know, as Dr. Murrell and Waggoner might have some opinions on that as well.
Hey, I feel in many instances, a chiropractor can be beneficial to a patient. I think that a good chiropractor, just like a good physician or surgeon, knows what he can or she can or can't treat. I certainly, if I had a spinal tumor, I wouldn't want to be treating with a chiropractor, but certainly I've had many a patient that we've worked with a chiropractor and their symptoms have resolved. And again, I've had chiropractors send me patients saying, this is at a point where chiropractic care is not appropriate at this point. Will you be willing to see this patient?
Excellent. Dr. Waggoner, do you have any thoughts or anything to add?
I think chiropractic manipulation can be beneficial, especially in an acute onset of back or neck pain. But I would caution patients to be a little bit hesitant to do any manipulations if they're having any, say, radicular pain or radiating pain into the upper or lower extremities, the nerve type pain, or if they're having any neurologic deficits such as weakness or the things like that, because I have seen in the past that could be worsened with chiropractic manipulation.
Excellent. Great. I hope that answers the question. The next question is the spine center in a particular location of OrthoSouth? And I will take a few minutes on this one and then hand it out to our panelists. The spine center, the reason that we call it a spine center is not due to its location, but just due to the multidisciplinary collaborative approach that we take throughout all of OrthoSouth that involves physical therapists, chiropractic services, our physiatrist and non-operative spine specialists, all the way to our spine surgeons. And you can get those services at any location where we have a clinic. So you have access to our spine team at whichever location is most convenient to you and fits in with your particular circumstances the best. And Dr. Murrell, would you have any thoughts or anything to add to that?
Yes. So I think there are two ways to organize a spine center. One is a physically centralized or a centralized physical plant. In our case, we realize our patients come from near and far. And so we've chosen to try to come to our patients as much as we have them come to us. And that's one of the reasons we try to place our spine physicians at our various locations. We just think it's more convenient for our patients. And it sometimes means we have duplicative services and that we have specialists in spine physical therapy that are at more than one location. But we just think it's a service that's worthwhile for our patients.
Excellent. Dr. Waggoner or Hauser, anything to add to that?
I don't think so. Between the two of you guys, I don't think I have anything to add.
Excellent. Thank you. Thank you. That was a great question. Another question here. Is there a way to avoid, or are there ways to avoid degenerative diseases and disorders of the back? Or are they more prone to being genetic? Are there preventative steps that people can take?
So I can take this one. So there are multiple factors that come into play with regards to degenerative disease in both the cervical spine and lumbar spine. There's a part of it that is genetic for sure. There's a part of it that is wear and tear and overuse over the years. But I think regardless of what is causing it, the best way to prevent might not be the right word because it's hard to prevent, but to some degree it is to have and stay on top of your core strength of both the muscles that support your neck and your lower back. So core strengthening and trying to incorporate that into your daily routine to some degree if you have a neck or back issues. And even if you don't, it can help prevent it going forward. I think that's the best way to prevent degenerative disease from getting worse and to kind of stay where you are and keep from having flares, over time. And I stress that to every patient that I see in the office, the importance of core strength and physical therapy, if necessary physical therapy, but many people can do it on their own. And I often instruct patients on exercises they can do on their own to try to keep things from worsening with time. And Dr. Waggoner and Murrell might have something to add, but I just think that core strengthening is so very important.
Excellent.
Agree with Dr. Hauser. Core strengthening is very important. Other things that we can do is to exercise regularly, keep our weight under control, and avoid using tobacco products such as smoking and chewing tobacco, because it's been shown that tobacco and nicotine can have detrimental effects on the discs and cause disc degeneration.
Very interesting. And Dr. Waggoner, if someone is diagnosed with an arthritic back, what is the progression of management of that condition?
Diagnosed with an arthritic back. I
Mhm.
think
Yeah.
being diagnosed with, or almost all patients are going to, over time, the natural progression of the spine is to develop some degeneration over time. So everybody to some degree is going to develop, as they get older, some arthritic changes or degenerative changes in their spine. Most people don't experience chronic pain with this, but if you do experience, pain which does not resolve after a couple of weeks of time, then the patient needs to come in the office, be evaluated. Most of the time, they will respond to conservative measures with anti-inflammatory medications, an exercise program, whether it's a home exercise program or physical therapy. If none of that is helping, then we obtain other imaging studies, and taking a thorough history and doing a thorough physical exam is also very important to determine, whether they're having any neurologic problems with it, and whether they're going to need any further treatment, such as injections or possibly surgery. So I just think it's a common problem to develop degenerative changes in your spine or arthritis. So again, most people those symptoms will resolve with time, but if they don't, we need to get them in the office and evaluate them further.
Thank you. Dr. Hauser or Murrell, anything to add to that?
I don't think so. I think that covers it for the most part. Yeah.
So I have one final question here, unless, and of course I would like to invite anyone who has any kind of lingering thoughts, feel free to type those into the chat. My question is for each of you, and we'll start with Dr. Murrell. When do you want a patient to come and see you, to make an appointment with you?
I think I'm going to ask, when you say when, do you mean when in the process of their?
Yeah, when if you were talking to somebody, would you say, you need to come in and see me?
Certainly, if they're unable to manage their pain, or if they're able to manage their pain, but they just feel like they've hit a wall when doing things on their own at home, then I think it's time to come in and see us and see if we can't put together a plan to try to get them back on track, try to get them back doing their daily activities, enjoying their life, and doing the things they like to do. So there's really never a time that it's too early or too late. But certainly, we're here for you, and when you need us, we want you to call and come in and see us.
Thank you. Dr. Hauser?
And I agree. I don't think it can ever be too early to come in. I think if there's any concern, and even if you just need some reassurance, a lot of people just want to make sure there's nothing that going on that's going to get worse, and they need some reassurance. And I'm happy to provide that any time. And I think any of the other doctors here feel the same way, just like Dr. Murrell just said.
Excellent. And Dr. Waggoner?
I agree with both Dr. Hauser and Dr. Murrell. We'd be happy to see them at any time. The things that we need them to come in emergently for, or to go to the emergency room for, would be the red flag type symptoms that Dr. Murrell was talking about earlier. And those would be things like just unrelenting pain, which is awakens them at nighttime, and they cannot get any relief at all. They need to obviously come in for things like that more quickly. If they're having any neurologic symptoms, such as progressive weakness in their lower extremities, or loss of bowel or bladder control, things like that would be things that we need to have them come in, urgently for. Other than that, the reason to come in would be, they can try conservative measures at home to begin with rest, ice, anti-inflammatories over the counter, and different exercises that they can usually get online or from our website. And if the symptoms don't improve after, a week or two, then they definitely need to get in and be evaluated.
Excellent. Thank you all. And as our final question, I just want to open it up to our panelists and ask if there's you have a last word that you'd like to put in or cover something that we have not yet covered. And Dr. Waggoner, I'll start with you. Just any final thoughts?
So what is can you go ahead and repeat the question again?
Sure. I think we've come to the end of our questions. So I just wanted to give you each an opportunity to provide any final thoughts before we adjourn for the evening. And if you have none, if we've covered everything, then that is good as well.
I think that we now have like you mentioned earlier, Melissa, that a complete multidisciplinary spine center. So we have, options to be treated from, we will evaluate you, whether it's one of the spine surgeons, one of the physiatrists, or one of the nurse practitioners or PAs can always get you in and evaluate you. And then we have a complete multidisciplinary approach to the treatment of spinal disorders. So we'll try as much as we can to treat these things conservatively. And most of the time people will improve with conservative treatment. But if not, and you do need surgery, we are there to help you with that too.
Thank you so much. Dr. Hauser, do you have anything to add or any last thoughts?
Just to echo what Dr. Waggoner just said, we have pretty much availability for everything necessary for the non-operative management of spine, and the vast majority of spinal conditions related to the neck or lower back will improve with non-operative management. And I think all of us try to utilize that first before jumping to surgery. And if surgery becomes a necessity, it's something that we'll discuss and go forth from there. But I think the main thing is just to remind folks that most of this stuff gets better without surgery. So if you come, you're not necessarily headed for surgery.
Excellent, great points. And Dr. Murrell.
Yeah, and I just want to remind everybody that we're here to get them better. And so if they do choose to come to OrthoSouth, take every advantage they can of their meeting with either one of the surgeons or non-operative physicians. And that goes so far as to not just always just sitting there nodding or agreeing, but asking us questions, challenging us with your problems to try to find an answer that fits your unique situation.
Fantastic. Well, everyone, thank you so much for your time tonight. Thank you for joining us. To our panelists, we appreciate you sitting down and just having this discussion. To everyone who is participating, if you do have any questions that come up later, feel free always to send those to me. That's mcandel, MKANDEL @orthosouth.org, and I will find an answer for you. This webinar session has been recorded, and by the end of this week should be loaded to our website, our YouTube page, and shared on our social media, so you can refer back to it as needed. Thank you again. I hope everyone has a fantastic evening.